So today, and for those who are going to be taking in this, this will be the first of a series of talks on osteoporosis. And other talks will be complementary, hopefully not duplicative. But we will cover a lot with regard to this disorder. Today, after me, Stavroula is going to talk to you about glucose homeostasis and bone remodeling. And then Aubrey Stock this afternoon, Eileen Fenoy, and Dr. Rubin will cover hypoparathyroidism. All right. Any questions from yesterday? Anything that I spoke about that kept you up last night? No? Okay. Didn't give you great concern. You were able to sleep well? Okay. All right. So I'm going to stand here. I guess I'm going to stand here. And so this is the beginning of this big discussion. And we're talking about an international problem. So it's not a problem locally for this country or even other countries, but for all countries. And to illustrate the problem, this is a slide that still is current, but it gives you a 100-year sort of biopsy of time with regard to the number of hip fractures in the world by regions. And the yellow refers to 1950, and the pink refers to 2050. And these are projections that Cyrus Cooper put together a number of years ago, but they're still more or less accurate. That everything's going up. Every region of the world is going to see more hip fractures. And Asia, in particular, is going to show the greatest increase. It isn't because Asians are at greater risk for osteoporosis. In fact, on the contrary. But it's because there are so many people in Asia. That's the point. But point is that this is a big problem, and it's getting worse. And in terms of worldwide prevalence, there are approximately 200 million women in the world who have this disease. They aren't all in what we call the aged category, over 80. But 1/3 of women are in what we call the younger category, between 60 and 70. Another bullet here, approximately 30% of women over the age of 50 already, if you look hard, not that they have clinical evidence, but morphometric evidence, have one or more vertebral fractures. And again, this is the same kind of graph that I showed you, but the numbers now are 6 million hip fractures worldwide by the year 2050, which is only how many years from now? 32 years from now? So half of these fractures are going to occur in Asia. And again, this is a population-based estimate. This is not inferring that the Asian population is necessarily at greater risk. Actually, in terms of vertebral fractures, the Asian population is at similar risk. But in terms of hip fracture and non-vertebral fractures, the Asian population is actually at lesser risk. And Dr. Walker is going to talk to you about what is the difference between the Asian skeleton, more the Chinese skeleton, because that's what we have studied, versus the Caucasian skeleton. From the U.S. point of view, again, more projections in terms of both osteoporosis and this category that we call osteopenia or low bone density. You can see how these numbers are really projected to be really quite extraordinary, both combining the diagnosis of osteoporosis and low bone density. Again, from the United States, 2 million fragility fractures are occurring annually in the United States. If you take a 50-year-old Caucasian woman and you project her lifespan out for the next 30 or 40 years, she has a 50% lifetime risk of having a fragility fracture. And those fragility fractures are divided into the big three: vertebral fractures, hip fractures, and the Colles fracture. If you want to just do some interesting comparisons, and I'm not inferring for a minute that osteoporosis is a bigger problem than breast cancer or prostate cancer. But if you look at the number of events, looking at women versus breast cancer as a diagnosis, or in men, the number of men who fracture versus men who develop prostate cancer, you see that it's very competitive. If you're looking at disease burden, we are seeing a lot of fractures. So I make allusions to the country of Armenia, and I will not be able to refrain from making more allusions to the country of Armenia because I go there a lot and we're doing a lot of things there. And a very prominent woman in Armenia, Narina Mamakoyan, who used to be head of the Armenian Osteoporosis Association, said to me a few years ago, and I thought this was quite well said, that osteoporosis is one of the most dangerous diseases of the 21st century. It's very well put. We're not just talking about a broken bone. We're talking about a disease that changes life and sometimes ends life, not something to be taken lightly. So this is a woman, sort of the prototypical woman who has unmistakable osteoporosis. And there are some features about this woman that are worth noting. One, she's sitting on a park bench. And as she is more and more sedentary, she is going to be losing more and more bone. She's not obese. You will very rarely see an obese person who has frank, not that obese subjects are not at risk, in fact they are at risk, but you will very rarely see an obese subject who has sort of what we call very severe osteoporosis. And that's partly because this woman can't eat that much. Because of her thoracic fractures, her abdomen has been pushed forward. She gets that abdominal pouch that a lot of women complain about. And she gets full early. So she is going to be the way she looks. As you may have heard, for every thoracic vertebral fracture, vital capacity is reduced by 9%. So people who have very severe kyphotic, scoliotic changes due to thoracic compression fractures, they actually have reduced pulmonary function. You can imagine her getting comfortable or not getting comfortable sleeping at night because she's just has disordered posture. And she will not live as long as her age-matched counterparts who do not have osteoporosis. Now, you can see this projection fairly well, and you can see a few things about this woman. You can see that she's wearing lipstick. You can see that she's had her hair done. You can see that she's wearing some kind of heel. Well, what does that mean? That means that she's trying to look her best. But you look at her, and she looks at herself in the mirror, and she knows she doesn't look the way she used to look, nor will she ever. So this is a disease that really takes your sense of yourself away. I see so many women who they just have a psychological deficit because of how their shape, posture, their whole bearing has changed. So let us not forget the men. I have remarked that in this disease, the men are the forgotten gender. But they shouldn't be forgotten. If you look at this data set, this is combining osteoporosis and osteopenia, about 45 million. About 1/4 of these individuals are men. And they actually account for, I don't have a bullet here, but they account for actually proportionately more of the economic burden per fracture than do women. And that's explained in part by the fact that when men develop their osteoporosis, they tend to be a bit older, 5 to 10 years older. And by being a little bit older, they are more likely to have comorbid issues. And those comorbid issues might cause more trouble. So actually, the hip fracture in a man who's typically going to be in his early 80s is going to cost more and be associated with greater morbidity and greater mortality. So this is going to come back over and over again. This is another one of David Dempster's great skeletal micrographs. This biopsy was taken, the top biopsy, was done by Elizabeth Shane a long time ago. And David Dempster was the one who did the micro-CT. And this set of matched biopsies, healthy versus osteoporotic, was and may still be in the Smithsonian as the sort of the prototypical example of what we're talking about when we say a person has osteoporosis. And again, to reiterate the point that the top panel shows too little bone, but it also shows microstructural disease. And the microstructural disease is the real challenge. We can solidify that disordered scaffolding pretty easily. We have a lot of drugs, and we're going to talk about that. But the challenge is going to be to put this skeleton back together again. And because without doing that, we're not really optimizing our goal, which is to restore microstructure and skeletal strength. Okay, so there's a lot to talk about. How do we get this way? How do we develop osteoporosis? And we have to start very early in life, because some of this discussion relates to the failure to achieve peak bone mass. And then when we have reached peak bone mass, by the way, I don't mean failure to accrue, this is actually not worded correctly. We all achieve peak bone mass. That's a given. The point of this is failure to achieve optimal peak bone mass, whatever is in our genetic apparatus to get to wherever we would like to be when we reach optimal peak bone mass. Have we reached that optimum value? And failure to accrue optimal peak bone mass is statistically going to come back in the later years. We know about age-related bone loss. There are situations of accelerated bone loss. And there are diseases that make the bone loss syndrome much worse. So let's go to this notion of failure to achieve maximal bone mass as an element in the pathogenesis of osteoporosis. And it is said, and Eileen Fenoy, when you see her this afternoon, she will probably make this point, that a major consequence in adulthood of poor skeletal health in childhood is osteoporosis. This is a slide that tells us what happens when we were younger and accruing bone, and you can see over the years up to 20 or maybe up to 25, but not much more, we're accruing bone. And this is due to bone growth. Our bones are growing in size, they're growing in shape, and we're modeling our skeleton. Modeling is different from remodeling. Modeling is taking quiescent bone that is not being remodeled. Most children do not remodel, but they grow bone on quiescent surfaces. And they grow bone on those quiescent surfaces in a way biomechanically, as the stresses and strains of life will put bone in some areas or another. And a perfectly healthy youngster who's growing and goes through normal puberty will have this kind of trajectory. They will accrue bone mass up to a certain point. They will maintain that bone mass somewhere in the 30s and 40s, so you all are, again, in that sweet spot where you're not losing, you're not gaining either anymore. And that's okay, but not forever, because sooner or later, you're going to join the ranks of the older adults, and bone loss is going to start. And it probably starts before, for the women, probably before the menopause. Probably begins a little bit before the menopause. So what are the factors that determine peak bone mass? Everything is genetic, it seems. You know, we're programmed to be what we are and to have whatever that's going to happen to us. And it's said that 60 to 80% of the acquisition of bone is genetically determined. Some of you know about the high bone mass genes that have been discovered, like the sclerostin gene, examples of how you can accrue bone in remarkable ways. For example, the diseases sclerosteosis and Van Boeckem's disease, primarily in the Dutch population, disease where sclerostin is knocked out, either as a point mutation or as a sequence of gene segments of the gene, not the transcribing region, but the non-transcribing region. But basically, these people have no sclerostin. And by virtue of no sclerostin, their Wnt signaling pathway is uncontrolled. And they grow bone until they die. And the ones with the homozygous disease, if it's sclerosteosis, they get into big trouble. If it's Van Boeckem's disease, they're okay. But they accrue bone. Their bone densities, like T-scores, are +5. So we have high bone mass genes. And those people, in a way, are lucky, or actually not lucky, because when it's homozygous, there are other issues that can occur. We don't know about the low bone mass genes. There's a consortium of genes that are, on the other hand, not good for our skeleton. But there's no specific gene that has really been identified as a low bone mass gene. Nutrition, calcium, vitamin D, protein, body size, body weight, exercise, smoking, and sex hormones during adolescence. That's a lot of things we're going to talk about. So this is a schematic of what I'm beginning to talk about, not just peak bone mass, but optimal peak bone mass. So you take example A versus example B. These are two youngsters who have accrued bone to a certain point. A did much better than B. So A starts out her adult life with more money in her bank. Her bone bank is fuller than the youngster in B, who doesn't do quite as well. And interestingly, the strongest predictor of bone mass in old age is bone density in young age. Because once you reach that point, A and B, that's it. You're not going to accrue any more bone. And if bone loss is going to occur at the same rate, let's assume that that's the case, youngster B, when she gets to 60 or 50, losing bone, in this case age-related bone loss, she's going to reach this magic number, -2.5, before patient A, because she starts out with more. It's like anything. If you have more money in the bank and you spend it at the same rate as somebody who doesn't have as much money in the bank, the one who didn't put money away as the other one will be broke before the other one will. It's simple discussion. So it would be nice if B could become A. What can we do in the growth period of life to maximize bone mass? And what are the things that our youngsters do that make it difficult to achieve their optimal peak bone mass? Now, we've got other problems with youngsters, and this is example C. And this is a real problem. And these are people, maybe they're very small in size, so this could be an artifact, because DEXA is a two-dimensional measurement, and as a function of size, the two-dimensional depiction of the DEXA image will unfairly read low in a small person and unfairly read high in a large person. So there are corrections for body size, and Eileen might talk about that. But on the other hand, there are disorders of childhood. There are genes that we've talked about. There are issues with puberty, late puberty, completely no puberty. And these youngsters can be at greater risk. And to get these up to B, or even up to A, is a real challenge. And so these individuals at C are really challenged. So let me give you a thought case. This is a patient I saw a few years ago, 53-year-old Caucasian woman, strong family history of osteoporosis, mother and father. She had her menopause 2 years ago. She's not taking estrogen. She's G1, P1. No fragility fractures, no other risk factors, no sedentary causes. The bone density was done because of the family history. And these are her bone density T-scores, -3 at the lumbar spine, -1.1 and -2.1 at the hip regions, and the distal radius is normal. Her labs are normal. Chem screen, serum calcium, 25D, PTH phosphorus, bone turnover markers, celiac screen, put in a PEP, whatever you want, they're all normal. So, what is this? Is this postmenopausal bone loss? Think about it. She had her menopause 2 years ago, and her T-score is -3 in the lumbar spine. It's hard for me to believe, unless she has some terrible disease, that she could go from a pretty good T-score in 2 years with loss of estrogen to get to -3. Clearly, she's got bone loss, we think, but maybe she hasn't even lost bone. Her bone density is low, maybe because she didn't ever acquire peak bone mass. Then it brings up the question, if that is the case, why is her distal radius normal? That's a little wrinkle here. But we've had situations like this, and when I can't be sure what that T-score is telling me, I mentioned this yesterday, I will do HRPQCT. So if this was a case of failure to achieve maximal or optimal peak bone mass, and she's lost a little bit of bone because she's now 53, her T-score is -3, we could do extreme CT. I can do it. And if I did, what do you think I'd find? What would be her microstructure if it was a matter of failure to achieve peak bone mass? What would you guess? Would she look like that picture that David Dempster took? I don't think so. She might be perfectly normal. Her microstructure could be completely normal. It is possible. And in fact, I've had occasion to note that. So it's a complicated discussion when you have an early postmenopausal woman who comes in with such a low T-score as to whether or not she has osteoporosis by the definition of osteoporosis, or whether she has low bone mass because she never got to where she wanted to be. But it may be an academic discussion because that T-score is low. And we're going to talk about how important that number is, because that is very powerfully predictive, independent of how she got there. So even if her microstructure is normal, epidemiologically, she's at risk.
So if we don't have a microstructure,
I know.
would you do a trabecular bone score or something?
Yeah, we'll hold that thought. The question is there an easier and cheaper and more accessible way of getting to that question of microstructure without spending $500,000 for an extreme CT machine? And the answer is yes, and Emery will hold that because we're going to get to it. So what percentage of her total body skeletal mass is low? Her lumbar spine is -3. Femoral neck, total hip, -1.1, -1.5. And distal third radius, which is right here, is normal. So knowing that, and if you know how much of the skeleton is cortical bone versus trabecular bone, I'll tell you, 80% of the skeleton is cortical bone, 20% of the skeleton is trabecular bone. The lumbar spine, or vertebral spine, is predominantly trabecular bone. So the compartment of the vertebra is 75% trabecular, 25% cortical. The hip is 50-50, half trabecular, half cortical. And the distal third radius, I'm not talking about the ultradistal, I'm talking about the distal third right here. You feel your arm right here. It's very hard. 95% of that site is cortical bone. Okay? So if the skeleton is 80%, the entire body's bone mass is 80% cortical bone, and this woman's distal third radius T-score is normal, can you infer that most of her skeleton is normal? Would you infer that, or would you say I'm off base? Seems logical. If the distal third is representing cortical bone, which we think it is. That's one reason why I like to do the forearm, because it gives me much more information with regard to total skeletal mass than either the lumbar spine or the hip or together. So that's why I do 3-site DEXA in everybody. And in this case, if you follow me and agree with my thinking here, she's got selective bone loss. Not to say that's not important, but she's got selective bone loss of the trabecular skeleton, but her cortical skeleton appears to be normal.
And so will that tell you that that looks more like a menopausal?
Yeah. Well, good thought. Yeah. So what? Because trabecular bone is metabolically much more active and much more sensitive to estrogen and androgen. It does add to the thought that this could be influenced heavily by estrogen deficiency, because that's when a woman becomes menopausal, and we're going to touch on that. The period of accelerated bone loss really focuses on the vertebral spine. That's a good point. And the estrogen deficiency state affects all bones, but because the cortical skeleton turns over so much more slowly, 1 to 2% per year, it takes longer before you see the effects of sex steroid deficiency than it takes when you looking at trabecular bone. So do you think she has osteoporosis, having had this discussion? What would you say? Yes, no, maybe? How many of you say she has osteoporosis? Okay. Anyone want to argue? We're okay, we can argue. No? Yeah, of course she has osteoporosis. She's got a T-score of -3. We don't know how she got there. And we're wondering what that means vis-a-vis her childhood. But we have to make the diagnosis, because we know what that T-score of -3 means. It means that she has high risk. And again, we'll talk about what that means. So what more information would you like to have about her?
Does she have any fractures?
Okay. Does she have any, we didn't get much of a history of FRAX, but you'd like to know whether she has, we know her, there's a family history of osteoporosis. We don't know about hers. There are a number of things you would like to know. We'll talk about the workup, so we'll touch on that. But you really want to work her up completely. You want to get I would get bone turnover markers. You want to get a PEP. You want to get urinary calcium excretion. You want to get, if we didn't do her phosphorus, you would want that. You'd want to do a complete standard workup. And this is another question that you want to wrestle with. She has a T-score of -3. Would you treat her with a drug? All right, well, think about it. Don't have to answer the question, but think about whether or not this is the kind of patient, 53 years old. She's going to live for another 30 years on average. And these drugs we use, we don't use these drugs for 30 years. All right, let's go back, bless you. Go back and talk about the principle. Sufficiency in calcium and D is as important in childhood as it is in adulthood. Exercise. In the, when we recommend exercise in our adult patients, we want them to walk. Walk's a great exercise. It really is. I mean, I have patients who say, doctor, how often should I meet with my personal trainer? They have personal trainers to walk with them. I mean, do you need a personal trainer to walk? But there's this notion that exercise is complicated and you have to be taught how to do this, how to do that. If they want a personal trainer, that's fine. I have no objections to a personal trainer. But walking is wonderful. It is, if you think about when you walk, every time you walk, you are stressing your legs, your hips, your back, and your paraspinal muscles. You can feel your paraspinal muscles every time you take a walk. So every step you take is stressing all those bones. The only bones that you aren't stressing are your wings, your arms. That's where walking doesn't do anything. But short of your upper extremities, it's fabulous exercise. Jogging, yeah, for people who like to jog, then that's a repetitive, percussive exercise. And of course, many patients, when they get to the age we're talking about, their knees have given out or about to give out, or they don't want to jog. They don't have to jog, but that's something. Treadmill is fine. Weight training, particularly for the upper extremities, you can ask them to carry little weights on their wrists when they walk. You can get these Velcro weights, and you can put in 1, 2, up to 5 pounds. You don't have to put 25 pounds on the arm. Really don't. You know, 1 to 2 pounds, 3 pounds is plenty. Tai Chi, it's amazing. There really are reports that associate Tai Chi with reducing fracture risk. Why is that? Why can that doesn't make any sense. Does it or does it? Why would you think?
Flexibility, decrease folds.
Yeah, it's probably balance. People who are doing Tai Chi are probably improving their balance, and by improving their balance, they're less likely to fall. That's the thinking about Tai Chi. And I have to put swimming in because, you know, because I like to swim. So I know the literature. I know swimming isn't good for your bones. And have you ever, you know, if you take fish don't have, they're cartilaginous bone. They don't have the kinds of bones we have. And so swimming, if you want to swim too much, you'll turn into a fish, and it's not good for your bones. That's the thinking. And it's not true. It's not true. Those of you who swim, how many do you swim? Some of you swim? Good. Well, you're resisting hydraulic forces. Unless you, or else you'll sink. You are resisting force through water. It's not anti-gravity, but it's hydraulic. That's one point. Secondly, it's an aerobic exercise. It's a wonderful exercise for fitness. And if you define fitness, there are all kinds of ways of defining fitness, but if you define fitness as your ability to consume oxygen, the more you swim, the more you do anything that requires aerobic effort, the more fit you are. And fitness has been correlated with skeletal strength. And just think about it. If you're really fit, however you get fit, you're feeding your brain, your heart, your liver, your kidneys, and your bones. So fitness per se is good. And I don't care how patients get fit. So my patients who say, I love to swim, doctor, but maybe I should stop swimming and do something. No, whatever you like. If you're doing that, it's good. Keep swimming. Don't change. It's not bad, and it probably is good. Now, for children, we're much simpler. You tell from pediatrics, this is what we tell children. That's what we want them to do. Do what the children do. But unfortunately, children these days don't do what children used to do. Exercise has not, however, been clearly shown to increase bone mass in the adult skeleton. Very difficult to show that any exercise by itself improves skeletal mass in the adult skeleton. And for patients who say, doctor, you know, these drugs, they have these very bad side effects, I'm going to do it nutritionally. We're going to talk about calcium and vitamin D, sufficient protein, and I'm going to exercise. And that's all I need, and I'll see you in a year. Well, you may go that route, because patients are going to help determine what they want to do. But they will not accrue skeletal mass by these means alone. On the other hand, exercise is great. It's great for strength, muscle strength, balance, and overall fitness. So I think exercise should be part of everyone's program, not just our osteoporotic patients, but our patients who are getting to their middle years when we learn that we're not totally immune to misfortune and disease. In childhood, on the other hand, exercise has been clearly shown to increase bone mass in the growing skeleton. There have been some wonderful studies. There have been matched twin studies where one twin does what children do. They play with their computers, their iPhones, sit at the television, and they're basically couch potatoes. And then the other twin is getting put into a really active exercise program. And within 1 year, the twin who is exercising clearly is accruing more bone mass than the twin who's not doing anything. So there's no doubt that exercise in childhood will accrue bone mass. This is a study that, not too old, that looked at this. They actually looked at a cohort of children in a school. I believe this was from Sweden. And they took a school, they took the children 6 to 8 years of age, and they gave them 40 minutes of exercise per school day for 8 years. And the control was a comparable school that did the usual exercise requirement in this country, which was 60 minutes per week. So you went from daily, one group had daily exercise, the other group had weekly exercise. And the relative risk of fracture fell for every year of the study. And at the end of the study, the relative risk of fracture was much less in the group that exercised. Now you'll say, well, children don't break their bones. Well, they do break their bones. Children break their bones. They break their bones because they're very active and they fall out of trees and they do things like that. And the second point about children, particularly when they're going through puberty, bone turnover is very high for a very short period of time. When they're growing, children grow. When they're growing, they're in a high turnover state. And for children as well as for adults, a high turnover state is a vulnerable state because you're making all these little micro stress lines. And with that in mind, there is a period in childhood where fracture risk is increased, usually in the context of an event, like an accident, not by walking down the street. But children are at risk for fracture. And in this study, it showed that that relative risk was markedly reduced in the children who exercised. So this is another example of exercise associated with protein intake. And the study looked at children who were 7 years old. They were boys. And they were followed, very interestingly, until they were young adults. And they looked at these 4 different groups: physical activity and protein intake. And if you look at the top, the blue, which just goes down to their physical activity was the maximum, and their protein intake was like, 57 grams per day. And when they were 7, their Z-scores were much higher than the other 3 groups that were a combination of physical activity and protein intake. And they tracked these children up to the age of 22, and they continued to be favorable to the other 3. Now, the study does not tell us over those 15 years, did they continue to have the same exercise program? Did they continue to have the same amount of protein intake? So we don't know. But it did seem to suggest that adequate protein intake and physical exercise in the prepubertal years were key to establishing peak bone mass. So children and adults are not getting enough exercise. Why? Well, for the adults, we've got our city environment with automobiles and mass transit. We have people still watch television, I suppose. We have the computer. We have the automobile. And we have fewer bicycles. When I first went to Beijing, China, this was 1994, I'll never forget the scene looking out. I was in a big high-rise hotel, and I was looking down on a busy street in Beijing, and it was fascinating. There were countless automobiles, but there was the same number of bicycles. And the bicycles and the cars were vying for territory. They were all on the same street. And it was clear what was going to happen in the next 10 or 20 years, and that's what happened. Now you go to Beijing, you look down from the same hotel, and there are no more bicycles. The bicycles are gone. The bicycles are still in China, but they're on the side paths, but it's a comment on what has happened to that country that depended on bicycles, and in this country as well. And children, again, the same environment. We've got television, we've got computers, limited exercise programs in schools. So that is a challenge for the pediatricians. In terms of exercise, even in childhood or any time in life, when a sedentary life, but really in something that leads to immobilization is going to lead to bone loss. We've talked about influencing growth of larger bones in children and peak bone mass, less important in adults. And we emphasize it in the aging skeleton for the reasons I pointed out. So we've talked about calcium a little bit, vitamin D a little bit, exercise a little bit. But overall, nutrition is something to take into account, particularly in countries where adequate nutrition is not a given. And the problem is called stunting. And what is stunting? Stunting is best described as you look at an elementary school child who's in the 4th grade, and he or she looks like she's in the 1st grade. And these are children who are born normally. They're not small for dates. The mothers are not overtly nutritionally deficient. And they grow normally for a period of time, 6 months, a year, year and a half. And then they stop growing. And it's not clear what is going on with these kids. Overall, poor nutrition, maybe they have parasitic disease or some chronic GI infection. But stunting occurs in the developing world and in parts of this country as well. So this is a picture of me and Don Juan, who is a bioengineer in the Department of Psychiatry here. He is from Hangzhou. And we were together. This is you like my Chinese tie? It's a really nice Chinese tie. I might wear it one of these days. It's a very nice tie. And this hospital had me welcoming. They had a banner, a sticker, a ticker tape for the whole day. Welcome, Dr. John Bilezikian from Columbia, United States. And we had a good time there, and we talked about a lot of things. And one of the things was stunting. In China, in 2002, 22% of the under 5 population had some evidence for stunting. And as the country has become more developed, this percentage has dropped. But as of about 8 years ago, it was still significant. And in Armenia, another country that's developing, about 15 to 20% of these children have evidence for stunting. So that's another thing that can contribute to the deficit in achieving peak bone mass. But then now we have to talk about age-related bone loss, accelerated bone loss. Clearly, once we've achieved that peak, we would like to maintain it for the rest of time. We'd like not to lose bone after we've accrued as much as we're going to accrue. And so we're coming to the other part of this curve. This is subject A, and subject A is going to lose bone as a function of aging. And it tends to be linear at whatever time it begins. And wherever that person started, if that person lived long enough, and depending upon where that peak was, that t-score of minus 2.5 looms ahead. What are the determinants of age-related bone loss? Well, certainly bone turnover is important. The adult turnover is rarely in balance, unfortunately. And as we turn over our skeletons, we're always losing a little bit more than we are gaining, imperceptibly so. It's very hard to show, even by measuring bone markers, but bone resorption is a little bit more than bone formation, leaving to a little bit of a deficit, unit by unit, day by day, week by week. There's also a thought that the osteoblast, and this is related to the first point, the osteoblast isn't able to compensate or to fill in the remodeling space as well as it used to. So the more you are turning over bone, the more you're going to lose bone, because for each bone remodeling unit, you're losing a little bit of bone. Somebody who's turning over 20 units in a period of time will lose more bone than someone who's turning over bone at the rate of 10 units in that period of time. One of the points about the anti-resorptives is that they bring down bone turnover and help to restore the balance, or at least the quantitative deficit in the rate of bone turnover. We also have sex steroid deficiency, and in sex steroid deficiency, we have an increase in the number of active osteoclasts, and those active osteoclasts dig those micro units of bone deeper, making it more difficult for the osteoblast to come in. So you have a combination with sex steroid deficiency of activated osteoclasts and rather inactive osteoblasts and osteocytes. And that leads to bone loss. So with women, we have the menopause period where bone loss is accelerated due specifically to estrogen deficiency. This period of menopausal bone loss varies from patients to patients. And by the way, not everybody experiences postmenopausal bone loss. That's not a given, although most women do. But the extent to which the woman experiences accelerated bone loss in this 5 to 8 year window after the menopause is variable. Some women will lose a lot, some women will lose a little. But this period of accelerated bone loss differentiates the men from the women. Because the men, as they age, don't have a menopause, or we call it an andropause, that is an abrupt cessation of sex steroid sufficiency. Yes, men can become menopausal if they're on Lupron for prostate cancer, or they're castrated for other reasons, or they become hypogonadal. A hypogonadal man will experience accelerated bone loss, just like a hypogonadal woman. And we will talk about this with regard to men. This issue of bone loss in men, you might think, is a function of androgen loss, because hypogonadal men, testosterone's low, androstenedione is low, DHT is low. But you know what else is low in men who become hypogonadal? Estrogen. Because testosterone goes to estrogen, and that's true. That's a truism. That's true for women and true for men. And the relationship between age-related bone loss in men is much tighter as it relates to estrogen loss in men than androgen loss. Estrogen, very important for men as well as women. Okay, so we've got accelerated bone loss due to estrogen deficiency, and we've got age-related bone loss, both together making things worse. After this period of menopausal bone loss, the line sort of smooths out, and then women are continuing to lose bone, but not at that accelerated rate. So again, looking at this diagram, we have patient A. She's going through menopause, and so she is going to hit this line faster than if she didn't have menopause-related bone loss. So let's say she took estrogen. Good idea. I think it's a great idea. When Tara comes tomorrow, she'll tell you it's a good idea. This won't happen. This will not happen. Unfortunately, it will happen when she stops. So she's going to take estrogen for 10 years. That's what we say these days. Is that right? How long do we use estrogen for?
So now that the American College is recommending that you don't have to stop it.
Oh, good.
Yeah.
That's great. Very good. Yeah, but it used to be.
The shortest
Yeah,
period
yeah,
of time is
yeah.
5 years, 5
Yeah.
to 10 years.
Yeah, because, well, if and when a woman stops, she's going to recapitulate accelerated bone loss. So if she takes it for 10 years, and she says, oh, you know, the risk of breast cancer is going up, and I'm going to stop, then this period of accelerated bone loss will begin 10 years later. There was a very interesting study of women who took estrogen for 10 years versus women who didn't. There was a 50 to 60 period, a decade. One cohort of women took estrogen and the other cohort did not. But they looked at them not after 10 years, but at the age of 80. Okay? So you had 50-year-olds, half of this group took estrogen for 10 years, the other half did not. And at the age of 80, there was no difference in bone density. There was no difference. So those who took estrogen were protected for that period of time, but then they lost it when they stopped. So the estrogen deficiency is, again, tied up with androgen deficiency in men. The loss of estrogen leads to cytokines that get stimulated. IL-1, IL-6 have been implicated in the bone loss. We will talk about rank ligand. We talked about it yesterday. Hello?
Sorry,
You
sorry
coming
for
in?
bothering
Yeah,
you guys
sure.
if you
Come on
can.
in. And then rank ligand gets into this, and then we have accelerated bone turnover and bone loss. So this is the Rotterdam study, a very famous epidemiological study, tracking bone loss over time. And you can see in the orange, the women are losing bone faster than men, and that's the menopause-related bone loss. And then later, you see the men in blue catching up to the women. So again, this early 50 to 65 period is when the women are losing bone, the men have not started to lose bone, and then later in life, the rate of bone loss begins, is similar between men and women. So that is menopausal bone loss, but there are other factors that can lead to accelerated bone loss. That is, we've got age-related bone loss, we've got menopause-related bone loss, and then we've got a host of other factors that can be related. Glucocorticoids, big problem. Anticonvulsants, you're going to hear about. The use of GnRH analogs, aromatase inhibitors, excess thyroid, and PPIs. We'll talk about PPIs. Then, of course, diseases, any malabsorption syndrome, hyperparathyroidism, hypogonadism for any reason, hyperthyroidism, Cushing's, and myeloma. There's a whole host of things that can lead to bone loss. But what about PPIs? PPIs are used by everybody, it seems. And you know, the New York Times every month or two says PPIs are bad for bone. And your patients say, doctor, I know my bones are bad because I've been on a PPI for 10 years. If you look at the epidemiology, there's no doubt that PPIs are associated with osteoporosis. It's a risk factor. And so the point I'm going to make is that epidemiology has never proved anything in life. All epidemiology does is to take A, observation, and observation B, and say there is a relationship between A and B. But it doesn't tell you that between A and B there are 8 jillion steps or 10 other mechanisms, or that it's really not causal. Epidemiology doesn't prove causation. It just says something is associated. So PPIs are associated with bone loss. But do PPIs cause bone loss? Think about it. What do PPIs do? They block gastric acid secretion. And the simple thought is, well, then you're not going to absorb calcium, right? But what we talked about yesterday was that's not true. If you take calcium carbonate with food, you don't need gastric acid. If you take calcium citrate with or without food, you don't need gastric acid. And the studies have been done to look at calcium absorption in the face of PPIs and no gastric acid under the conditions of protein with calcium carbonate or no, just fasting with calcium citrate. And calcium absorption is perfectly fine. Well, then you're going to say, well, PPIs are proton pump inhibitors, so they block the pump in cells beyond the GI tract, like the osteoclast. Okay? The osteoclast pumps. It's a very active transport cell. But if the PPI is going to the osteoclast and blocking the pump, it's going to render the osteoclast dysfunctional. So it should be an anti-resorber. It should be good for bones. So what is this? Well, Bill Leslie, my dear Canadian friend from Manitoba, is wonderful. Bill is wonderful. He does such great work. And he posed the question, is either greater morbidity and or pre-existing fractures more likely to be associated with the prescription of PPIs? This is the Manitoba, it's a fabulous database. And what he found was that looking at prescriptions for PPIs, those who had low bone density were more likely to be prescribed PPIs. So it was a self-selection. For some reason, people who have low bone density are more likely to be using PPIs at the beginning than people who don't. So it's a very good example of how we can make conclusions of causation when it's really not the case, and there's another explanation for why A and B are related. So Bill thinks PPIs may be associated with fracture because they are more likely to be prescribed among those at increased risk for osteoporosis. All right, here's the list, and it grows every year, of the differential diagnosis of osteoporosis. Now, you are not going to rule out every one of these diseases in your patients who have osteoporosis. You will never get anything done if you try to rule out every one of these diseases. You have to be selective. You take a history. We still do a physical exam. and you come up with what would be a reasonable differential diagnosis that would narrow this list down to a more reasonable one. And here are some of the big things that you'll think about in terms of secondary causes of osteoporosis. Hypogonadism, we've talked about that in women. That's pretty straightforward. In men, it isn't so straightforward. Men who develop osteoporosis may well be hypogonadal, but you don't know that. We're endocrinologists. We think we can know somebody who's a hypogonadal. We can't. Men who become hypogonadal don't look hypogonadal. It's not like they've been hypogonadal since birth. And they won't even give you a history, often, of behavioral or what have you. So in men, you need to rule out hypogonadism, even if there's no suggestion of hypogonadism. COPD, that's pretty straightforward. Rheumatoid arthritis. By the way, COPD and rheumatoid arthritis are etiologically related to bone loss, independent of the treatments for COPD and RA. So steroid independent, those two diseases are directly associated with bone loss. We know about myeloma, D deficiency, hypercalciuria. Again, in men, 10 to 15% of men will have an idiopathic hypercalciuria to help explain the bone loss. And then the drugs we have talked about and we'll learn more about in time. So the pathogenesis of osteoporosis is a lot. There's aging, menopause, other risk factors lead to increased bone loss. Low peak bone mass in childhood also is important for the low bone density. And then we have the issue of bone quality that feeds into this. And very importantly, fall risk. If you never fall, will you ever have a hip fracture? Let's take a woman whose T-score is -5. Her hip T-score is -5. And she never falls. What are her chances of having a hip fracture?
Sometimes you fall for the fracture.
Yeah, well, that's what I'm getting at. So how many times, thank you for bringing this out. That's what I wanted you to bring out. How many times does a woman or a man walking break his hip and then fall? The hip fracture occurs before the fall. If that's true, then someone with a T-score of -5 is going to break her hip, sure as she walks. But what are the chances of falls, fractures occurring before the fall versus the fracture occurring in conjunction with the fall? We have the data. And it's somewhere between 90 and 95% of the fall causing the fracture, not the fall occurring after the fracture. So if a woman doesn't fall, no matter how bad her bone density is, she's not likely to break her hip. It's true. She may break her back, but she's not going to break her hip. So we're going to talk about that some more. All right. So the diagnosis of osteoporosis. In the old days, 30 years ago, the diagnosis of osteoporosis was made by easy. Take a look. And you can still make the diagnosis of osteoporosis. There's the poster man for the National Osteoporosis Foundation. This woman clearly has osteoporosis. You don't need to be a healthcare professional. You don't need DEXA. You don't need bone turnover markers. You don't need extreme CT to make a diagnosis of osteoporosis. But we would like to have some quantitative measure. And again, as I mentioned, the great man, Fuller Albright, started with saying that this was a disease of too little bone. And this is the picture that we have discussed, and this is the definition that the consensus conference from the NIH, headed by Ann Klebanski, proposed. A disease of compromised bone strength. The word bone density was changed for bone strength, predisposing to an increased risk of fracture. So how do we make the diagnosis of osteoporosis? Short of the classic fracture, it's by DEXA. DEXA revolutionized our field. DEXA is only 32 years old. It became used widely in our country and then throughout the world in 1986. So it's relatively new technology. And you all know the DEXA machine and some features of DEXA. It's extremely safe. I had a patient just on Monday, and she said, "Doctor, can I skip the DEXA for next year?" I do yearly DEXA. I said, "Why do you want to skip the DEXA?" She said, "Well, all that radiation." And I said, "Oh, well, tell me about your mammography." "Oh, I'm having mammography next month." "Do you have mammography regularly?" "Yes." And I said, "Well, do you know how much radiation you're getting exposed to from mammography versus DEXA?" Of course, she doesn't know. "Do you know how much radiation you're getting exposed to by DEXA versus taking the next plane trip to the Caribbean on vacation?" "No." So it's minimal radiation. It's about 1/5 to 1/3 of a chest X-ray exposure. So it's really a safe technology from that point of view. It's extremely accurate. The precision can be as good as 1%, depending upon your facility, whether or not you know how to do DEXA, and whether the operator has been properly trained. We have normative population databases. Of course, the bottom point, it correlates very powerfully with fracture risk, and it has become the diagnostic standard for osteoporosis. So this is a very, very important slide because it relates bone density to risk of fracture. For every standard deviation reduction in bone density, there is a doubling of fracture risk. Now that is really amazing when you think about it. Bone density is a surrogate marker. The endpoint is fracture. So for every unit reduction in bone density, you're doubling fracture risk. So can you think of another surrogate marker that is as powerfully related to an end result? Well, you can think of cholesterol as a surrogate marker for coronary artery disease. You can think of blood pressure as a surrogate marker for stroke. Well, let's take those two. And you can think about bone density as a surrogate marker for fracture risk. Of the three, which is the least powerfully related? That is, surrogate marker to end organ effect. Cholesterol, blood pressure, bone density, which is the least predictive? You can guess. Likely to be right.
50-50.
What?
50-50.
50-50. All right. It's the cholesterol. Cholesterol is not, compared to blood pressure and compared to bone density, cholesterol doesn't make it. Blood pressure is good. Blood pressure is very powerfully related to risk of stroke. But this is too. That tells you really very, very helpful. And it is the key, not the only, but a key risk factor for the fragility fracture. And to a certain extent, it reflects an effect on bone strength. This is a cadaver study looking at failure load versus trochanteric bone density. We don't use trochanteric bone density anymore. But there's a straight line relationship to the lower the trochanteric bone density, the lower the failure load. And so that is a measure of bone strength. So it isn't just bone density, but it's to a certain extent bone strength. So you've seen this slide or something like this before. This comes from the World Health Organization that kind of set DEXA on the map. And this came from the Consensus Conference in 1994. The WHO got together and looked at the epidemiology of fracture risk over a woman's lifetime. They looked at women 50, 60, 70, 80. And they correlated the T-score, and the T-score, as you know, is a measure of standard deviations from the peak bone mass of a young woman, and you relate that to the young adult peak, not the age-related peak. That would be the Z-score. The T-score of minus 2.5 gave a 50% lifetime risk of fracture. And that was considered to be big. If you have a 50% risk of fracture at a T-score of minus 2.5, they felt that that was equivalent to a condition that they called osteoporosis. It's very interesting. They took a risk factor and they used it to define a disease. Kind of neat. And what we do is to say minus 2.5 is that cut point, below which the perimenopausal woman, postmenopausal woman, and the male, 50 years of age or older, can be defined as osteoporotic. Younger women, you cannot use the T-score or the Z-score to define osteoporosis by itself. And that's true for men too. And when Dr. Shane talks to you a week from Wednesday, a week from today, she's going to go into this in some detail as to how do we define osteoporosis in premenopausal women. We cannot use the T-score alone. In yellow is this condition called low bone density, or in parentheses, osteopenia. Patients come to me and say, "Doctor, I have osteopenia." And they act like it's a disease. And it's very difficult to say, well, you don't have a disease. It's a condition that may or may not lead to frank osteoporosis. But it is low bone mass, and we need to evaluate these women and men in ways that we will talk about to try to determine whether they're at risk. The T-score of minus 1, so low bone density is minus 1.0 to minus 2.5, and those who have T-scores better than minus 1, within one standard deviation of that young adult peak bone mass, are normal. So the thinking in this country, and it's not universal, but in this country, is that if the T-score is minus 2.5 or below, it's a high-risk condition, and patients should be seriously considered for treatment. Those who are better than minus 1.5, with rare exceptions, would be considered to be low risk, and we typically wouldn't go a pharmacological route. But is this never land of osteopenia that really gives us fits as to what to do? How do we advise these patients the best? The operational definition of osteoporosis in this country is a T-score at the lumbar spine or hip, either the total hip or femoral neck, of less than minus 2.5. The use of this surrogate marker to define the disease is now ingrained in our minds, and also a major determinant of the, let's use the word payers, or insurance companies, that pay for the treatments. In fact, they have forgotten that patients who have a fragility fracture have osteoporosis. They have forgotten that. Patients who have had a fragility fracture and have a T-score of minus 2.1, according to our country's thinking these days, that is the people who don't know as much as you know, would go so far as to say they don't have osteoporosis because the T-score isn't less than minus 2.5. If we rely exclusively on the T-score definition of osteoporosis, we will not diagnose most of the osteoporotic fractures that occur in postmenopausal women and men over the age of 50. So Dr. Cyrus is going to talk to you about her views of the diagnosis of osteoporosis next Tuesday. And Dr. Cyrus did this very important study called the NORA study. Anyway, you can read the title. What Etch did, Dr. Cyrus did, this was a huge population survey of over 200,000 women. And she measured peripheral bone density and had a standard curve, monophasic standard distribution curve. And if you draw a line down from the peak, you'll see the average t-score was between -1 and -1.5. And then what she did was to look at the fracture rate in the yellow bars. And this is no surprise. As bone density goes down, the yellow bars go up. We know that. The lower the bone density, the greater the fracture risk. The next build on this slide is the key point. She then looked at the number of women with fractures. Not the risk of fracture, but the number of women with fractures. And you can see the blue bars peak at around -1.5. So actually, more women who have this category of low bone density or osteopenia are going to fracture than women who have frank osteoporosis. And the cut point of -2.5 only takes in a relatively small number of women who will fracture. Their risk of fracture is high, but the number is low. In the women who have osteopenia, the risk of fracture is low, but because there are so many more women with osteopenia than with osteoporosis, the numbers are going to be high. So if we don't start paying attention to these osteopenic women and their other risk factors, we're going to miss them, and they're going to get fragility fractures.
Is this a combination of spine and hip, these fractures?
I'm sorry?
Is this a fracture a combination of spine and hip?
Yeah, this was, I think this was all osteoporotic fractures. I don't recall, it wasn't one or the other, but they were fragility fractures. They were vertebral and non-vertebral fractures. The bone density was peripheral, but then the study was, another study was done to, and this was the other study that looked at central bone density with hip, and you saw the same thing. The peak of fractures was occurring at a t-score that was even better than -2.5. Only 17% had a t-score. Only 3% of those who had frank osteoporosis had a t-score less than -2.5. So a prior fragility fracture is clearly a powerful risk factor for additional fractures. Whether or not, and I put diagnosis in quote, whether or not the t-score is in the osteoporotic range. And I think, to paraphrase a former president, and maybe within your lifetime, when he was running for president, he said, "It's the economy, stupid." Remember? Who was the president running for president who said that? Well, he didn't say this, but I'm paraphrasing him. This was Bill Clinton. Bill Clinton was running for president. He was told, and over again, it's the economy, stupid. He didn't say stupid, but don't forget the economy. That's what's wrong with this country. That's always a major theme of presidential elections. Well, it's the fracture. Come on, let's not forget the fracture, because that's the problem. That's the end point of the disease. And once the patient has that first fracture, it's a house of cards. You can know what's going to happen next. And what's going to happen next is going to happen very soon. Within a year, there is a 20% risk of another fracture. That's in someone who hasn't had a fracture. But if someone's already had a vertebral fracture, one, more than one, or more than two, the risk of another fracture goes up a lot. So it really is an urgent problem, because if we don't recognize that fracture and take measures as we do, then there will be, inevitably, another fracture, and it will happen sooner than later. As a function of the severity of the fracture, you can do this by morphometry of the fracture itself. The worse the fracture, again, the greater the risk of another fracture. The problem is that we, as a country, as healthcare providers, are not recognizing the fracture. This is an old study, but unfortunately it's still true. The number of patients who had a non-vertebral fracture, only 25% of this group was evaluated or treated, while 75% of these women who had a distal radial fracture went home to have another fracture. And these fractures that can be seen on routine chest x-rays are not even recognized. This is a study from France that looked at a series of chest x-rays that had been done for whatever reasons, and they went back and looked at the lateral chest x-ray, and they found 126 fractures in this cohort of 900 or so. And only half of the overt fractures were ever noted in the radiology report, and only 23% were summarized, and the diagnosis in these people was even less. So this is a clear, obvious vertebral compression fracture was not being picked up by the people who were reading the films. And looking at HEDIS measures, what are being expected of a standard of care, you know, beta blockers after a heart attack, everybody gets put on a beta blocker. 90% of people in this country who have had a heart attack will be on a beta blocker. 71% have mammography, and unfortunately only 29 or 30% of individuals with osteoporosis are being treated. Part of the problem is the patient saying, "Doctor, if you had fallen the way I fell, you too would have broken your arm." This happened to this couple. The woman tells me this, and the husband says, "Doctor, she's right. She just tripped." There's sort of a disconnect there. But I know you have patients who will say, "This was a bad fall. I tripped, and you would have broken your ankle too." Or everybody wants to attribute the fragility fracture to trauma. And we do distinguish between fragility fractures and trauma to a certain extent. A fragility fracture is a fall from a standing height, no matter how you fall. You tripped on your own shoelace, but you fall, you break your arm, whatever, you have a fragility fracture. If you're in an automobile accident, or you ski into a tree and break a bone, that's called a traumatic fracture. And that's not necessarily an osteoporotic fracture. But it's been shown more recently that even those who have trauma-related fracture, they may have some disposition to make them at greater risk, because not everybody in an automobile accident breaks their bones. In fact, the high bone mass gene, the LRP5 gene, was discovered by Bob Recker, who's at Creighton, in the context of a big, bad automobile accident. It may have been a van. There were like 10 people in this van. The van tripped, rolled over, and of the 10 people in this van, 9 of them had multiple bone fractures. One person had no fractures whatsoever. And Bob Recker was intrigued by the woman who didn't fracture. And her T-score was like +4. And that led to the discovery of the high bone mass gene and the family that was so protected. So even a traumatic fracture, you kind of wonder a little bit whether or not that person might be predisposed. So the T-score has superseded the definition of osteoporosis. It's superseded the endpoint event, the fracture, and it has influenced a lot of the payers and policymakers as we have overemphasized the T-score. We know, as we said, the fragility fractures occur in subjects not known to have osteoporosis by T-score. They do have osteoporosis, though, and we need to be able to work them up. One problem is that we're not aware enough as clinicians to take the next steps. So this seems so obvious that we should make the diagnosis of osteoporosis by T-score or the fragility fracture. They're both equally valid as diagnostic criteria. The fracture is the endpoint of the disease. The T-score is a risk factor. And if that is the case, and this graph I showed you before where so many women were sustaining a fragility fracture but didn't have a low T-score, that kind of implies that there are other risk factors that are important, that it isn't just the bone density that is responsible for fracture risk. And this gets into this discussion of what are the other risk factors that we can use. So you all know the FRAX, you access it, and this was a very major advance. What it did was to quantitate these other risk factors that are more or less independent of each other and more or less independent of the T-score. And you can use these key risk factors along with the bone density test, but actually you don't need the bone density test to do FRAX. You can leave that blank. You'll still get a FRAX score. If you put the bone density in, you'll do better. The bone density that we put in is the femoral neck bone density, and the way this drop-down menu works is that they want to know what the actual, not the T-score, they want to know what the actual bone density is. They want to know what machine you've used, the GE Lunar or the Hologic or the Norland. And then you answer the questions as noted here, yes, no, yes, no, yes, no. And then you get two numbers: the risk of any fracture, the absolute risk of any fracture over 10 years, and the risk of a hip fracture over the next 10 years. In the United States, we have determined when it is cost effective to treat based upon what the absolute risk is over the next 10 years. And those numbers are 20% for any fracture and 3% for a hip fracture. So those are useful. That's taking into account all the major risk factors. Not all of them, but the major ones. Just remember when you discuss this with patients the following. You tell the patient your hip fracture risk is 3.5% over the next 10 years. And you're at high risk. And you should be treated. Perfectly reasonable statement. And she says to you, wait a minute, doctor. You told me my risk of a hip fracture over the next 10 years is 3.5%. Does that mean that my risk of not having a hip fracture is 96.5%? The answer is yeah. She says, so I have a 96.5% chance of not having a fracture. I'm going to go with those odds. Keep away those drugs. This is a mindset. You have to deal with that. You can say, well, you know, if you get a hip fracture, it's 100% risk. And if you have a hip fracture, forget the economics of the cost, the morbidity, and the mortality. 20% risk of death over the next year after the hip fracture. So does a patient want to take that risk or not? You have to have that dialogue. So these are the other risk factors: age, prior fracture, current glucocorticoid use, family history, very important. And you can play with this, by the way. You should play with this. That is on your computer. You could add glucocorticoid, take it away. Put in smoking, take it away. Put in family history, take it away. And you'll see what the relative risk the importance of each of these factors is. They're not all equally weighted. And you can learn this just by putting it in a fictitious person, just to see how they are important. They're all associated. They're all quasi-independent of the t-score, and also pretty independent of each other. So this is an example of aging. As we know, as we get older, risk goes up because bone density goes down. But if you look at the importance of aging independent of the bone density itself, so take this bone density and look at this younger group, the isobars just barely come up from baseline as bone density goes down. But for the same bone density, if you take a 70-year-old, 75-year-old, 80-year-old, the risk is much greater. So aging by itself, independent of the bone density, is conferring risk. The older you are, for the same bone density, the greater the risk. Here's another example by using the t-score. Age 50, t-score is minus 2.5. Doesn't matter what the fracture risk is. It says it's 12%. But if you have the same t-score of minus 2.5, and that person is 70 years of age, now her risk of fracture is doubled. Okay? So that's a nice example of how one of these risk factors plays in to giving you a better sense of what risk is for the same bone density. And they vary in importance, and this was just giving the different risk factors and their relative importance of them. And the algorithm takes that into account. Another thing about the FRAX is that it's country specific. So these risk factors are weighted differently according to where the population is. It's not a universal thing. It has to do with the country. So in the United States, I showed you this, 55-year-old woman, her weight is whatever, and these are her risk factors or not, and this is her risk of a fracture, any fracture or... Now, I'm going to show you the same FRAX, but I'm going to change the country. Okay? 9.8 and 3%. This is Romania. And the major fracture is less than the hip fracture is a little bit more. I mentioned Romania because when I was in Armenia, we picked a country that we thought was closest to Armenia in various ways because we didn't have our own country-specific data. So we picked Romania. I won't go into the reasons why we picked Romania. And so we used the Romanian FRAX data, and when you put in Armenia, you got the Romanian database until we got our own database in Armenia. Okay? So now I'm going to show you Armenia. Remember these numbers. They're even lower. So the same person, that is not the same person, but same risk factors, from country to country, the risk varies a lot.
How long would, if someone's a recent immigrant?
Yeah, I know what you're going to ask. I do not know how to answer that question. Yeah, so a recent immigrant, that's easy. I would go back to the country. Yeah, as someone who's been to this country within the 10 years,
Okay,
I would say,
how long?
yeah, you know, who knows? That's a very tough question. Very good question. I do not know how to deal with that one. But I have some cut point. But I don't know that that's right. Yeah. Okay, but so country specificity is important. It becomes now a more complicated discussion because going back to the definition of osteoporosis by DEXA, now we know that we can get much more information by putting in the other risk factors. So why are we restricting our definition of osteoporosis to the bone density value as a single risk factor and not putting all the risk factors together? seems logical for us to do that. And so this is the proposal that Dr. Cyrus and I and others have proposed, that you have another way of making the diagnosis of osteoporosis. Not just the fragility fracture, not just the T-score, but the FRAX score, if it meets that fracture threshold. So when do we use FRAX? We use it in people who have low bone density. It is also useful in subjects who don't have bone density, and this tool was designed to be used in the middle of India, China, countries that don't have DEXA. But we don't use FRAX if the T-score is less than -2.5. That's in this country. Or if there's a prior fragility fracture, because that's already a diagnosis. There are countries, particularly Europe, I don't know how many of the European countries, but certainly UK, where they don't follow the T-score. They will use a FRAX score even if the T-score is less than -2.5. We do not use FRAX in premenopausal women, in men under the age of 50, and those who have been previously treated with pharmacological agents. And that's because we just don't have the data to know how predictive these factors are. Now, FRAX is not perfect. It doesn't take into account bone turnover and whether or not bone loss is accelerated. It doesn't take into account the lumbar spine bone density, just the femoral neck. It doesn't take into account how much glucocorticoids are being used, rate of bone loss. Secondary causes, except for rheumatoid arthritis, are de-emphasized. And it's a 10-year risk. It's not a lifetime risk. So it's got imperfections. You can adjust the FRAX if there's a discrepancy between the lumbar spine T-score and the femoral neck T-score by more than one T-score. And you would adjust fracture risk. In this case, there's a 2 T-score difference, -1.5 versus -3.5. You adjust it by 10% for each T-score. You're at variance between the two. So in this case, if the fracture risk is 18% for any fracture, you're going to adjust the risk by 20% because it's 2 T-scores away, and that then makes the risk of fracture from 18% up by 20% to 21.6%. So you can adjust by this adjustment, and you can also adjust for the glucocorticoid use. This is the most common secondary cause of osteoporosis, and we endocrinologists say that steroids are used for everything but Cushing's disease. The rheumatologists don't like this slide. They think I'm insulting them. And the dermatologists don't like this slide either. But you can adjust for glucocorticoid use. The assumption is that the patient is on between 2.5 and 7.5 milligrams of prednisolone or the equivalent, and you use the unadjusted FRAX model. But if the dose is greater than 7.5, you adjust the risk upward by 15% for a major osteoporotic fracture and upwards by 20% for a hip fracture. So in patients who are on high-dose steroids chronically for more than 3 months, the risk is greater, and you will adjust that way. FRAX isn't perfect because it doesn't take into account microstructure. And getting back to your question, Emery, how do we take into account microstructure in a clinically accessible way? The TBS score is the way we can do it. The idea of the TBS score is shown here. This is a forest canopy. On the left, this is a healthy forest. There are no holes, very nice carpet looking from a bird's eye view. And looking on the right, this is not such a healthy forest. There has been a forest fire, and there are many little holes here. And the analogy is bone. On the left, and looking at the microstructure of bone, that would be equivalent to a lumbar vertebrae that is very homogeneous and smooth, while this not so homogeneous, rather heterogeneous structure of forest would be analogous to a very porous bone. And this imaging can be done by your DEXA machine. Your DEXA machine has the image of the lumbar spine, and DEXA will now adjust for that if you have the TBS software to allow you to do the TBS adjustment. This shows that TBS is independently a risk factor for fracture. If you look at the T-score, normal osteopenia, osteoporosis, versus the tertiles of TBS, you see that the tertiles, as they get to worse and worse, the risk goes up. And as you are osteopenic or osteoporotic, the TBS score adds even more. So TBS is additive to risk as defined by the DEXA machine. Similarly, if you have the FRAX, the major osteoporotic probability, low, moderate, high, FRAX is adjusted also by the TBS. The higher the fracture risk, along with the lower the TBS score, the greater is the risk. So the FRAX gets modified, bone density gets modified, and now what you can do, if you have the software on your machine, you have an opportunity to adjust by clicking on that menu, putting in the TBS tertile score, and your FRAX score will be adjusted. How many of you have that software on your machine? Okay, no, most of you don't. It's not $500,000. It's only 10. So Dr. Cyrus is going to talk to you more about this diagnosis, and we're saying that there are 3 ways of making the diagnosis of osteoporosis. So I'll go for just one comment about distal forearm. It's a little kind of, we don't know how to make the diagnosis of osteoporosis with a distal forearm fracture. A 64-year-old woman who falls off a curb and lands on her outstretched arm. She breaks her wrist, and she has a T-score of -2.2. I think that's the kind of fragility fracture that we would say is an osteoporotic fracture. On the other hand, a 50-year-old woman who crashes her roller while rollerblading, breaking her wrist, and has a T-score of -1.3, that's a more difficult call as to whether or not that's a traumatic fracture, and you would be less likely to make a diagnosis of osteoporosis in that way. Okay, now I want to point out one other thing about FRAX. The risk of a fracture over 10 years has to be also considered in the context of your risk of death. If you're 95 years old and you have a FRAX score or whatever, it's a 10-year risk. What is your risk of dying if you're 95 years old over the next 10 years? That risk of dying is fairly significant. So FRAX takes into account country-specific data with regard to the risk of death. The older you get, the more the risk of death becomes important in this calculation. And at some point, your T-score may be -4. But if you're 94, FRAX will reduce your risk of fracture over 10 years because you'll be dead in 10 years. Very interesting concept. It's a competing risk. You need to have data on death statistics for the country in order to properly use FRAX. Okay, so FRAX takes into account your risk of death over the 10-year period. The younger you are, of course, the less important it is. The other important risk factors that are not skeletal, we've talked about fall risk, sarcopenia, Neil Binkley's favorite area, to discuss. Frailty, congestive heart failure, hyponatremia for some reason. I don't understand, but hyponatremia is a risk factor. FRAX doesn't deal with any of this. But you are going to take into account everything you can when you're thinking about it. And so let me give you an example of fall risk. So, you know, it's a wonderful example. Patients, and even if they don't have osteoporosis, this is not a good idea, but this is an accident waiting to happen. So we define osteoporosis as a skeletal disease characterized by microarchitectural deterioration that can be diagnosed by the fracture, the T-score, or by FRAX. And this is a syndrome that includes skeletal and non-skeletal risk factors that eventuate into high risk. On the left are the skeletal factors, and on the right, as we're becoming more and more familiar with them, we're going to probably take them into account. So just as a thought about this, after we've gone through this, definition 1 is skeletal disease diagnosed by skeletal indices. That's what we've been thinking up until now. And now we're moving into an area where it may be a syndrome that includes skeletal and non-skeletal factors that eventuate into high risk.